we have two bioceramics products. Root ST is a pre-mixed bioceramic sealer that comes in a syringe form, while Root PT is a pre-mixed bioceramic putty that comes in a capsule form. Composition, both are composed of calcium aluminosilicate compound as a bioactive component, zirconium oxide as a radiopacifier, which does not cause any discoloration and thickening agent. Uses, of course, where Root ST is a bioceramic sealer, is used as a permanent root canal filling material in conjunction with gutta-percha, while Root PT is used in vital bulb therapy, either direct and indirect bulb capping, partial, complete bulbotomy, regeneration, revascularization, as a retrofilling material in apical surgery, lateral and focal perforation repair, internal and external root resorption. Of course, nowadays there are so many studies that support the use of bioceramics, if anyone is interested. And here is a recent study that was published in July 2023, a critical review of the material properties guiding the clinician's choice of root canal sealers. In this study, they compared and classified the hydraulic cements according to the percentage of the calcium silicate content in the composition. And they classified the hydraulic cements as follows. Low charge, which is lower than 20% of calcium silicate content. Medium charge, which is higher than 20 and lower than 40%. High charge, which is equal or higher than 40%. According to VERICOM's material safety data sheet, where Root ST contains from 50 to 60% of calcium silicate content, which is considered the highest of BC sealer in calcium silicate content worldwide. What is hydraulics? Hydraulics is the injection of the bioceramic sealer into the root canal system, then applying our master cone gutta-percha to the full working length, which act as a piston that push the sealer into any susceptible microanatomy that may exist. Is it powerful enough to fill the whole root canal system to get a 3D obturation? Let's find out. This is a video. Not working? Not working? Okay. Here are the examples. Here is a lateral canal filled related to upper lateral incisor. Here is a lateral canal filled related to upper canine. Here are two lateral exits filled related to lower first premolar. Here are two lateral canals filled related to upper second premolar. Here is an isthmus area filled related to upper first premolar. Here are multiple lateral canals filled related to upper first premolar. Here is a lateral canal filled related to a lateral radiolucency. As you can see, a lateral canal related to the mesial and the apical delta related to the distal root of lower second molar. And here is a lateral canal filled related to the mesial root, and here is a 3-year recall. The lateral canal is still filled with the sealer. The sealer did not wash out, did not resorb. Here is an isthmus area related to the mesial root and the lateral canal filled. And here is a 5-month recall. The lateral canal is still filled with the sealer. Here are multiple lateral canals filled related to upper first premolar. Here is a lateral canal filled related to the palatal root of upper first molar. Here is a loop filled related to the mesio-buccal root. And here is the 3-year recall. The loop is still filled and there is complete healing. Here is a variety of upper central incisors. Upper central incisor has more than 40% incidence of accessory canals. And here is a variety of lateral canals. When patency not achieved, what to do? Here is a type C lower second molar. I wasn't able to achieve patency after I injected the sealer and added tapered auxiliaries, seared off the gutta-percha and did some coronal compaction. I got 2 lateral exits filled with the sealer. Here is a 3-month recall after indirect composite restoration. In this also I wasn't able to achieve patency. After I injected the sealer, I got some bizarre microanatomy. It was filled with the sealer in both mesial and distal roots. In the distal root only, I wasn't able to achieve patency. As you can see, the sealer got a tortuous lateral exit, was filled with the sealer. Here also, I wasn't able to achieve patency in the distal root. As you can see, the sealer flows through this tiny microanatomy. Here is also, I wasn't able to achieve patency I got an abrupt 90-degree lateral exit filled with the sealer. Root ST will help you achieve the optimum apical seal on almost all types of cases, especially in the following case scenario. Long roots more than 25 millimeter, extremely curved roots, multi-planar curvature, S-shaped curvature, in case of conservative shaping, teeth with external root resorption, compromised roots for strengthening, and large veriapical lesions as promotes healing. This canine with 32 millimeter length, multi-planar curvature combined by conservative shaping related to upper first molar, multi-planar curvature combined by conservative shaping related to lower second molar, multi-planar curvature combined by conservative shaping related to lower second molar, extremely curved and long roots, upper second molar. Here's a case of upper second molar with severe curvatures. Here's the master apical files. Here is the immediate post-obturation using the sealer. We can't do any more techniques like this. It's easy. Inject the sealer, add your getaperca cones, seal the getaperca, and you're done. And here is another X-ray view. Separated file retrieval. When we retrieve a separated file, we lose some dentin. We compensate the lost dentin using bioceramics as it bonds to dentin and act as a mono block. Here, after we retrieve the separated file, we compensated the lost dentin using bioceramics as it bonds to dentin and act as a mono block. As you can see, here is a furcal canal related to the furcal radiolucency, and here is 1 month after crown placement. In this case, as you can see, there is a large radiolucency. After I retrieved the separated file, the canals were oozing exudate, and I had to finish in one visit. So I injected the sealer and finished the case, which is very risky, by the way. And here is the 8 months record shows complete healing, and the sealer is still the same, did not washed out, did not resorb, which is a very, very tough test for any bioceramic sealer. The sealer can be easily washed out. Here also, after we retrieved the separated file, we compensated the lost dentin using bioceramics. This is a treatment case that went from simple to very difficult. During getapercha removal, I separated 5 instruments, and one goes beyond the distal apical foramen. But I managed to retrieve all 5 instruments, and here is the immediate post-obturation. And this is the 1.5-year recall, shows complete healing. Healing of a large radiolucency. Here is a large radiolucency related to the mesial root. Here is a preoperative X-ray. And here is a 2-year recall, shows almost complete healing. This is another retreatment case. Some sealer extrusion occurred, and here is the 3 months recall, shows significant reduction in radiolucency size. And here is the 1-year recall, shows complete healing. The sealer did not resorb, did not wash out, did not prevent the healing. Here is also a 6 months recall, despite there is a separated file beyond the distal apical foramen. Here is a 4-year recall, also shows healing, and the lateral canal is still filled with the sealer. 8 months recall shows complete healing for the furcal radiolucency. Complete healing after 8 months. Another 1.5-year recall shows complete healing. 10 months recall, complete healing. This is a tough retreatment case. We did surgical and non-surgical retreatment in this case. And here is the immediate post-retreatment, surgical and non-surgical retreatment. And here is the 5 months recall, shows significant reduction in radiolucency size. Another tough retreatment. Here the canals were blocked using flowable composite, unfortunately. Here is the immediate post-retreatment and obturation. Here is the 5 months recall, shows significant reduction in radiolucency size. And there is a nice microanatomy filled in one of the mesial roots. In cases of limited accessibility and limited mouth openings, this is a lower wisdom with nice internal anatomy. Long-term recalls. When we use a new material, we must recall and follow up the cases as much as we can to see how the material will interact by the years. So this is a 7-year recall for a tough lower wisdom. The sealer still exists in the isthmus area, did not washed out. This is also another 7-year recall for upper lateral and upper canine. The sealer still exists, did not resorb, did not washed out. And here is another 7-year recall for a tough calcified case for upper first molar. And this is a 7-year recall. The sealer still exists. Okay. Vital bulb therapy. Anyone here practicing vital bulb therapy? Hello? 1, 2. Okay. Okay. American Association of Endodontists position statement on vital bulb therapy. Vital bulb therapy techniques are means of preserving the vitality and function of the dental bulb after injury resulting from trauma, caries, or restorative procedure. Vital bulb therapy procedures have traditionally included indirect or direct bulb capping, partial and complete bulbotomy. We have 5 steps to do. We have 5 steps to do in one single visit to get a successful vital bulb therapy case. Number 1, diagnostic consideration for vital bulb therapy. You should have sound diagnosis. The current AE diagnostic terminology assigns a vital bulb to one of 3 categories: normal, reversible bulbites, irreversible bulbites. Caries management. Complete caries removal. Any residual caries left behind will affect the prognosis. You should do complete caries removal. Use of sodium hypochlorite. Sodium hypochlorite is an antimicrobial solution that provides hemostasis and disinfection. Hemostasis can be achieved within 5 to 10 minutes either via direct passive irrigation or in a sodium hypochlorite soaked cotton pellet. Use of contemporary material, which is the bioceramic sealer or the putty, which has improved barrier quality than the calcium hydroxide. Immediate placement of a permanent restorative material. The advantage of the immediate restoration is the prevention of the micro leakage and protection of the biomaterial layer, reduction of the postoperative sensitivity and thermal conductivity. The primary goal of vital bulb therapy is the creation of optimal conditions for bulb tissue repair and preservation. This paragraph, a pre-treatment diagnosis of irreversible bulbites is not necessarily an indication for bulbectomy, as more conservative treatment could be considered. This means that we can do bulbotomy in cases diagnosed with irreversible bulbites, and we'll see this. Where would be different clinical applications? Vital bulb therapy. As you can see here, we did direct bulb capping. The body is inside the bulb horn. And here is a 4-year recall, the bulb horn returned intact again. This means that the barrier was formed. This is a successful direct bulb capping tooth. Here is the tooth was completely asymptomatic, responds normal to cold with no any radiographic finding. Here is another 1-year recall for direct bulb capping. As you can see, there is a barrier was formed. The tooth was completely asymptomatic, responds normal to cold with no any radiographic finding. This is direct bulb capping for lower second premolar. And here is the 3-year recall for direct bulb capping and 2-year recall for the root canal complete healing. This is also another 3-year recall for direct bulb capping. Tooth was completely asymptomatic, responds normal to cold with no any radiographic finding, and there is a barrier was formed. Even in the anterior teeth, in the aesthetic zone, we can do direct bulb capping, and here is a tiny exposure capped with putty, and here is immediate post restoration and X-ray. As you can see, the putty can be easily detected in the radiograph. It's highly radio opaque. The X-ray on the left is immediate post direct bulb capping. The X-ray on the right is 1-year recall. Tooth was completely asymptomatic, and here is the 1-year recall clinical image. No discoloration occurred in the central. And this is a trauma case for upper central incisor. We did complete bulbotomy. This is a case with external cervical resorption. We did also complete bulbotomy. And here is the 1-month recall, shows nice tissue healing. And the tooth was also completely asymptomatic. This is another trauma case for a 7-year-old girl. Came was like this. We did complete bulbotomy. As you can see, the roots not fully formed yet, still open. Here is the 10 months recall, shows complete maturation of both roots. and this is a 10 months recall clinical image. There is no discoloration occurred in the central, so you are free to use this material in the aesthetic zone with no fear of discoloration. Unlike most MTA brands, this causes massive discoloration. Even white MTA causes this discoloration. Here is a direct bulb capping for lower second molar, and here is the 3-year recall showing barrier formation. Here is the barrier, red arrow pointing and the barrier. Look at the difference. Left X-ray from the right X-ray. Okay. Direct bulb capping for lower first molar. Here is the 1.5-year recall. Here is the 4-year recall showing barrier formation. Okay. Here is a 50-year-old male who came complaining severe pain related to his lower second molar. Upon taking a radiograph, I found a deep carious lesion near the bulb related to the lower first molar. Now, what will be your treatment plan here, knowing that the first molar was completely asymptomatic? What you will do in such case? Okay. Simply, I did root canal treatment for the lower second molar, as the bulb was inflamed and has to be removed. As you can see, profuse bleeding, dark red profuse bleeding. And I managed to do direct bulb capping for the lower first molar, as the bulb was healthy and could be kept alive, so I did direct bulb capping. Here is the 1-year recall. Here is the 2-year recall. As you can see, there is a barrier that was formed. Here is the barrier that was formed. Here is the red arrow pointing at the barrier. Direct bulb capping for upper first premolar, partial bulbotomy for lower first premolar, and here is the 1-year recall, shows narrowing in the bulb chamber indicating barrier formation. Complete bulbotomy for upper second premolar, partial bulbotomy for upper first molar, partial bulbotomy for upper first molar, partial bulbotomy for lower second molar, partial bulbotomy for lower second molar. It's a repeatable procedure. Even in cases of bulb polyp, as you can see, there is a bulb polyp here. We did partial bulbotomy. The patient became completely asymptomatic after. Here is a partial bulbotomy for lower first molar. This is a non-bleeding exposure, so we can't do direct bulb capping. We enlarged the exposure site to a partial bulbotomy site, and we did partial bulbotomy. Here's a complete bulbotomy for upper first molar. Even in deep caries, I did partial bulbotomy, and here is the immediate post bulbotomy. Even in fractured cusps, here is a fractured mesiolingual cusp. I was able to get the margin build up, and I did complete bulbotomy, and here is the immediate post complete bulbotomy, and this is a 1-year recall. Everything goes good. Starting from this case, the diagnosis is irreversible bulbitis. Irreversible bulbitis. As you can see, there is a dark red profuse bleeding came out. After removal of the coronal bulb tissue, I was able to achieve hemostasis and the attachment of the bulb tissue to the canal walls. I did complete bulbotomy. This case also was diagnosed with irreversible bulbitis. Again, irreversible bulbitis, we did complete bulbotomy. Also, complete bulbotomy for a case diagnosed with irreversible bulbitis. Even in cases of bulb stones, here is a detached bulb stone. After I removed it, I was able to achieve hemostasis. We bought our putty material, and we did the final restoration, and the patient reported completely asymptomatic. In this case, also, the patient reported completely symptomatic. After we accessed the tooth, I did also partial bulbotomy. As you can see, just partial bulbotomy. We bought our putty material, and we did complete restoration. 2 days after, the patient reported completely asymptomatic. Complete bulbotomy for upper first premolar. Okay. Root canal treatment and vital bulb therapy in the same tooth. Can we do that? Can we do root canal treatment and vital bulb therapy in the same tooth? Let's find out. Okay. Here is a 9-year-old boy who came complaining severe pains that awakes related to his lower first molar. Upon taking radiograph, I found a deep carious lesion near the bulb and the incomplete maturation of the distal root. Upon exposure, dark red profuse bleeding came out with little amount of pus. Pus came out in this case. Okay? As you can see, after access to the tooth, dark red profuse bleeding came out. The clinical image on the right after trials to control the bleeding. This image told me that the mesial bulb is unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I did capped the distal bulb using the putty, while I did root canal treatment to the mesial root. Here is a confit X-ray. Here is immediate post-obturation for the mesial using root ST and the putty for the distal root. And here is the X-ray on the left is 18 days recall. The X-ray on the right is 30 days recall. The boy was completely asymptomatic. And here is the clinical research that supports the procedure. Combination of non-surgical, endodontic, and vital bulb therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbitis and apical periodontitis. And here is the 14 months recall, shows complete maturation of the distal root. This means that the bulb stayed alive and continued the growth of the distal root. The X-ray on the left is 1 month recall. The X-ray on the right is 14 months recall. I think the difference is crystal clear. Here is a part of the literature about vital bulb therapy. Treatment outcome following direct bulb capping using bioceramic materials in mature permanent teeth with carious bulb exposure. Retrospective study. Success of direct bulb capping using mineral oxide aggregate and calcium hydroxide in mature permanent molars with bulbs exposed during carious tissue removal. 1 year follow-up. The randomized controlled trial in Journal of Endodontics 2019. Teeth with carious bulb exposures and reversible bulbitis can be treated successfully with direct bulb capping. MTA proved better than calcium hydroxide in terms of both success rate and pain intensity. Systematic review and the meta-analysis, Journal of Endodontics 2015. Direct bulb capping using calcium hydroxide or mineral oxide aggregate, a meta-analysis. MTA has a higher success rate, results in less pulpal inflammatory response, more predictable hard tissue barrier formation. Pre-mixed bioceramics, a novel bulb capping agent. The pre-mixed bioceramics possesses a favorable result and all the properties comparable to the currently recommended material for direct bulb capping, MTA. The results are comparable or even superior. Bulbotomy of symptomatic permanent teeth with carious exposure using mineral oxide aggregate. Bulbotomy using MTA could be a good alternative for root canal therapy for managing symptomatic mature permanent teeth with carious exposure. Success of coronal bulbotomy in permanent teeth with irreversible bulbitis. An evidence-based review. Coronal bulbotomy is an evidence-based, safe, and predictable treatment that can be offered to adult patients with teeth with irreversible bulbitis as a substitute to root canal therapy. Again, one more study. Vital bulb therapy in permanent teeth diagnosed with symptomatic irreversible bulbitis reports with long-term controls. Vital bulb therapy with partial or total bulbotomies using bioceramic under aseptic conditions is a viable treatment that will have long-term success in permanent teeth with irreversible bulbitis when indicated correctly. One more study. Vital bulb therapy for permanent teeth with diagnosis of irreversible bulbitis, biological basis and outcome from a bulb biology perspective and data from clinical trials. Partial and full bulbotomy using calcium silicate cements are successful treatment modalities for teeth with carious bulb exposure and symptoms indicative of irreversible bulbitis. Remember, the best root canal treatment is the one you can avoid, and the best obturation material is what God's created, which is the dental bulb. We'll root PT as a root canal filling material. In this case, I retreated the lower second molar while I filled the distal root using the butty. I filled the whole distal root using the butty. You can do obturation with the butty material. I did this case 6 years ago. 2 years after, the patient came complaining severe pain. After I took a radiograph, I found a radiolucency under the distal root only. So I retreated the distal root and I filled the whole root using the butty. And here is the clinical research that supports the procedure: selective root retreatment, a novel approach. 2 days after, the patient reported completely asymptomatic. I only retreated the distal root. In this case also, this was a female colleague, came complaining. I retreated only the distal root. I filled using the butty. And here is the 1 month recall shows significant reduction in radiolucency size. And she became completely asymptomatic, despite the excluded getapercha. This is a trauma case for upper central incisor. I did complete root canal system obturation using the butty. This case also a trauma case with an open apex. I did full root canal system obturation using the butty material. This is a massively destructed upper central. I did apical plug for the open apex, and then I bought 2 fiber posts to build up the tooth. This case also, I did apical plug using the butty. Here also I filled the whole root canal system, the mesial and the distal, using the butty material. Hydraulics power. Bioceramics are a real savior and a game changer material. How? How bioceramics changed our daily practice? Perforation repair. This is a case of upper first molar with large perforation. There is a perforation defect after repairing using the butty material. And this is a 5 months recall, shows nice healing. This case also, I did 6 years ago. I repaired using the butty, despite I can repair this area using the composite resin, but I decided to use the butty to see how the material will interact by the years. I can follow up the case. And here is the 4-year recall. The butty is still the same despite the composite as the distal margin was ditched, which is a very tough test for any bioceramic material. The butty can be easily washed out by the oral cavity environment, but thanks to the quality, the butty survived. This is a referred case from a colleague. He wasn't able to find the mesiobuccal canal. Here is a file in the perforation site. Here is the perforation site periphery after removal of granulation tissue, after detection of the mesiobuccal canal. And here is immediate post-obturation, and here is immediate post-repair. And this is immediate post-obturation. I repaired using the sealer and the butty. And this is a 1.5-year recall, shows nice healing. And the sealer, the butty still exists. External root resorption. This is a female colleague who came complaining severe pain and swelling related to her lower first molar. Upon taking a radiograph, I found a massive radiolucency related to a massive external root resorption of the distal root. We decided to give the tooth one more chance, so we removed the getapercha, and here is a large H file in the resorptive defect. I decided to obturate the mesial root first because the distal root was oozing blood and exudate. So I blocked the distal orifice using Teflon, and I obturated the mesial root first. Okay? After that, I did the same in the distal root. I injected the sealer, put the getapercha cone, and here is the immediate post obturation. The sealer extruded. Actually, it's quite impossible to get a dry field in this area. And this is how external root resorption may look alike in a radix root of lower first molar. This is another case. This is a 4 months recall, shows significant reduction in radiolucency size. And the sealer still exists, did not washed out, did not resorb. By the way, the sealer can be easily washed out by the blood before its final setting. And here is the 8 months recall, shows more healing. The sealer still exists, did not washed out, did not resorb. And here is a conclusion from a study that was comparing different PC sealers worldwide. They found that root ST was found to be the most effective for attachment of human periodontal ligament stem cell on the set surface. Day 0, 4 months recall, 8 months recall, and here is the 2-year recall, shows complete healing, and the sealer still exists, did not washed out, did not resorb. Intentional replantation and the crack management. I did this case in 2013. I did direct bulb capping using calcium hydroxide, the dical. In 2017, unfortunately, apical periodontitis started to appear. We did root canal treatment. In 2019, tooth almost completely healed. Unfortunately, in 2021, a horizontal crack pattern started to appear. As you can see, here is the methylene blue dye staining the crack site. We decided to give the tooth one more chance. I removed the whole getaperca. I filled the whole root canal system using the putty. Unfortunately, the patient still have symptoms, so I extracted the tooth, cut the apical part of both root, then put back again into the socket, and here is the immediate post-replantation. Here is the 3 months recall, shows significant reduction in the lucency size, and the patient became completely asymptomatic. This is another intentional replantation case, referred case from a colleague for management of a separated file in a dilacerated mesiolingual canal. Unfortunately, I wasn't able to neither bypass nor retrieve the separated file, so I extracted the tooth, cut the apical part of both root, then put back again in the socket. Here is the immediate post-replantation. Deep split management for non-microscopic clinicians. Here is a case of upper second premolar with Vertucci type 7. Vertucci type 7 has the anatomy of 1, 2, 1, 2. And here are some tips and tricks to manage such anatomy. Number 1, stick to the reference point, buccal cusp, palatal cusp. Number 2, precurve all your instruments, your hand files, your rotary files. Number 3, shape both canals together. What I mean by shaping both canals together, when you start shaping the buccal canal, for instance, with 2004 file, you do the same for the palatal. 2504 for the buccal, 2504 for the palatal. 3004 for the buccal, 3004 for the palatal. Why? Because if you shape the one canal to the master apical file, every time you put the file to start shaping the other canal, the file will tend to enter to the larger one. So you find difficulty to enter to the narrower canal. And that's what I meant by shaping both canals together. And of course, hydraulic condensation technique, inject your sealer of the getaperca and Yundar. And of course, sonic activation and polymer needles is indicated in such cases. Here is another Vertucci type 7, has the anatomy of 1, 2, 1, 2. The difficulty almost in this part. You will find the file hit like in a wall. You have to redirect your file to enter to the apical part. Another Vertucci type 7, 1, 2, 1, 2. With the same technique. Another type of splitting, buccal and lingual canals with nice microanatomy filled with the sealer. Here is also another splitting buccal and lingual canal, obvious in the shifted X-ray view. This is another level of splitting. As you can see from the preoperative graph, here is a one main canal and 2 tiny splits. Okay. Here are trials to scout. I try to reach the splits. I cannot see them. I cannot see. I'm trying to scout my way out. Here is one split and the main canal. Here are the try to make getaperca harder. I precurve it, put an ice cube, spray it with an endo ice, trying to make it more hard, to make it more stiff, to be able to introduce in these tiny splits, but I cannot do this. So I decided to depend on another strategy, which is the hydraulics power. So I chose the largest getaperca cone that gives me the toughest tug back. This getaperca cone here was 4506. Okay? Then I down bagged the getaperca cone till the level of the split. So I blocked the main canal first. I blocked the main canal first. After that, I injected a sealer and added the rest of the cone. As you can see, the tiny splits started to be filled with the sealer. And here is the lateral canal started to appear. After adding more sealer, and I added tapered auxiliaries, mainly taper 4. Taper 4, getapercha, searing of the getapercha and doing some coronal compaction, and you're done. And here is the immediate post. I have heavily filled and buffed splits filled with the sealer, and the lateral canal also was filled with the sealer. This is another type of splitting for the lower second premolar. During a scouting trial, 3 splits were detected. This is by the naked eye, I cannot see. I just put my file, take an X-ray. Here is the master apical file for the splits. Unfortunately, I separated a file in one of the splits. And I tried to bypass. It was a very, very tough bypass, by the way. I cannot fully bypass the separated instruments, so I decided to depend also on the hydraulics power. Here is a confit X-ray. Here is the immediate post-obturation using the sealer with root ST. As you can see, the sealer flows beyond the separated file. And here is the immediate post-obturation for both the lower first and second premolars. This is another lower second premolar with splitting. And here is a nice microanatomy. The sealer, make it clear, make it obvious. This is another or different X-rays view. Okay, here is our last case. This is a lower first premolar that was a part of a bridge with multiple splits. During scouting trials, 2 splits were detected, 3 splits were detected, 4 splits were detected. Here is the master apical file. Here is the confit X-ray, and here is the immediate post-obturation using the sealer with root ST. And here is a quote from my mentor, Dr. Alan Nasser: if you're always worried about failure, you will never reach out for success. Thank you so much, ladies and gentlemen. I hope you enjoyed the presentation. Thank you, thank you. Any questions? More than welcome. Thank you. Okay.
Thanks for your amazing presentation.
Thank you so much.
I have just some questions about
Okay.
management of partial or complete pulpotomy. Do you have any considerations about the age of the patients? Any limitations?
For me, no.
Why? Let me start as I think. When you have direct pulp capping,
Okay.
shiny pulp, the cells that will be able to repair are the odontoblast. But when you don't have the odontoblast, who's gonna repair? Stem cells. So in old age, you don't have stem cells.
How old?
As I think 35, according to the references.
35?
It will be less than the available at the young age. So who's going to repair?
Do you have a paper for this?
Yeah. Documented papers that stem cells
Just one?
No.
We have no.
So you don't have any age limitations?
No. Once I have the criteria, I do vital bulb
Okay,
therapy.
question number 2.
Okay.
When you do a complete pulpotomy,
Okay.
the same question, who is going to repair?
The bulb itself will go into repair.
Which cell of the pulp?
Odontoblast.
Odontoblast is not available in the root.
You know, the main criteria of the barrier is mainly fibroblast.
Fibroblast when you have irritation. And fibroblast is going to be fibrosis, calcium deposition, and calcification.
It's a sterile necrosis. It's a sterile necrosis, bacteria-free.
Yeah, but we are talking about the worker. Or
Fibroblast.
Fibroblast.
The most abundant cell type in the dental bulb.
It's perfect. This is the right answer as I think. I'm agreeing with you in this. But the line of fibroblast will go to fibrosis, calcification.
With MT, no. With butty, no.
It's the same
It doesn't
thing.
act like this.
It does not relate it to the material. It's related to the factor who's going to repair.
No. The material have a big role. Do you know Bulbotec?
Yeah. The same thing.
It causes calcification,
Bulbotec.
necrosis. It's highly irritable to the bulb.
Here
the bulb-
we have the same factor. There is a trauma. Trauma means irritation, means inflammation.
Okay.
So who is going to repair? In shiny pulp, we know that the odontoblast are the main factor.
Yeah.
In exposed pulp, especially in young age, we have the stem cells.
Okay.
As I think the percentage of stem cells 5% to 8% of the coronal part and 1% in the radicular part. So in complete pulpotomy, who's going to repair?
The fibroblast.
Fibroblast, the line of the fibroblast ends with fibrosis and calcium deposition. So fibrosis.
Just a superficial layer, not deep down in the root. Just the coronal part, till the orifice level. No deep, not complete calcification, if it's happened. We have multiple follow-ups here. No calcification.
For
of
how
it.
long? Your follow-ups?
4 years.